two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our episode number 90. And today I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Hi, Swapnil. Good evening.
Good evening. So I guess with the Omicron variant now, the things are getting much better in most parts of the world. How's things going in India now?
Things have been pretty much better in the last few weeks. The number of new cases of COVID has come down, which suggests that the Omicron wave is also coming to an end probably. And we look forward to a few weeks of quietness in the COVID ICU.
Yeah, that's correct. So I guess overall number of cases in COVID ICU are decreasing day by day, and which has obviously bring some normality back to our lives, I guess. That's kind of very timely now that we are going to discuss another landmark non-COVID related trial, which was recently published in New England Journal of Medicine. And this trial has got quite a lot of significance, I must say. First of all, this is a multi-center, large randomized controlled trial involving large number of patients. And also it was conducted by ANZIC CTG group. And it has actually given a very clear answer to the question. The trial which we are going to discuss today is PLUS trial, which is basically comparing the Plasmalite 148 versus saline solution. Now, just to give a bit of context to this trial, we all know that intravenous fluids are the most commonly used drugs in intensive care unit. Now, there are various types of intravenous fluids, crystalloids and colloids, and the debate between crystalloids and colloid has slightly gone on the back foot. Now, we know that there is a very limited place for colloids, especially the 4% albumin, only in a really select subgroup of patients. So crystalloids still remain the mainstay of fluid therapy in intensive care unit. And with regards to crystalloids, there are various crystalloid options are available, including 0.9% sodium chloride, Ringer's solution or Hartmann solution, or Ringer's lactate, Ringer's acetate, and also newly emerged crystalloid, which is Plasmalite 148. Now, some of these solutions can be categorized together into balanced multi-electrolyte solutions because the pH is close to plasma, the sodium and chloride concentration is almost close to plasma, and that's why they're called as balanced multi-electrolyte solutions. Also, they have additional electrolytes such as magnesium, calcium. So these solutions are thought to be better than 0.9% sodium chloride solutions or the saline solutions, predominantly because of the low salt content, including low sodium and low chloride content. Now, there's a physiological rationale behind that. High chloride concentration was thought to be associated with increased risk of acute kidney injury and increased risk of death in certain cohorts of patients. There are multiple trials were published in this topic previously. The two landmark trials were SPLIT trial, which came from New Zealand 4 ICU's open label cluster crossover trial, which did not show a difference between the saline solutions and the Plasmalite solution. And then the second landmark trial was published recently from Brazil called as BASIC trial, again, which did not show any difference between the two solutions. However, there was another trial called a SMART trial, which was published from US, which was a single center open label cluster crossover trial, which actually showed that 0.9% sodium chloride solutions cause more harm. So there was this kind of conflicting evidence on this topic. And that's why investigators from ANZIC decided to carry out this multi-center large randomized controlled trial with the hypothesis that 90-day mortality among critically ill adults would be lower with the use of fluid resuscitation and therapy with Plasmalite 148, which is also categorized as balanced multi-electrolyte solution compared with saline solution. So this trial is quite a landmark trial. So Dr. Checo, Can you please walk us through the methodology and the results of this trial, please?
The PLUS randomized controlled trial was conducted across 53 participating ICUs in Australia and New Zealand during the period between September 2017 and December 2020. Patients were judged to require fluid resuscitation if they were expected to be in ICU for a minimum period of 3 consecutive days. The study excluded patients who required a specific type of fluid, like, for instance, if the clinician deemed that 4% albumin is appropriate in a particular scenario, go ahead and use that. And this patient, of course, will not be included in the study. If the patient had any disqualifying fluid for resuscitation, if the patient was at imminent risk of death, if the pre-existing life expectancy was less than 90 days, patients with traumatic brain injury were excluded because previous evidence suggests that the use of a balanced crystalloid solution in preference to normal saline may worsen outcomes in traumatic brain injury. And also patients with risk of cerebral edema were excluded from the trial for the same reason. So the design of the study was a randomized controlled trial in permuted blocks of varying size, stratified according to center. The study fluids were supplied in identical 1 liter bags. So it was a blinded study. And the same fluid was used for resuscitation for a period of 90 days or while the patients were in ICU. Once the patients were transferred out of ICU, any type of fluid could be administered and the protocol was not followed. The original sample size that they calculated was of 8,800 patients for 90% power to detect an absolute difference of 2.9 percentage points in the 90-day mortality, assuming a baseline mortality of 23%. However, during the course of the COVID pandemic, things started going all right, and the study was at loggerheads with large numbers of COVID patients. So they cut down the sample size to 5,000 as against the initial 8,800, and the 90% power for an absolute difference of 3.8 percentage points, assuming the same baseline mortality. So the sample size was reduced from 8,800 to 5,000 because of the COVID pandemic emerging during 2020. The characteristics of the study population included a total number of 16,828 patients who were initially screened. 11,791 were excluded. Plasma light group had 2,433 patients and the saline group had 2,413 patients. However, in the 90-day analysis, there were quite a few exclusions because of lack of consent to carry out the study and unknown clinical status. So the final numbers were 2,433 patients, as I mentioned, in the plasma light group and 2,413 patients in the saline group. The patients were well matched at baseline. The median duration of treatment with assigned fluid was 6 days in both the groups. The median volume of fluid administered during the duration of the study was 3.9 liters in the plasma light group and 3.7 liters in the saline group, which is pretty much similar. Patients who received plasma light had a higher pH compared to those who received normal saline, as you would expect. The chloride levels, as again you would expect, was higher with saline compared to plasma light. The creatinine levels were similar at baseline. Now let's look at the outcomes they studied. The primary outcome was death from any cause at 90 days. Death occurred in 530 of 2,433 patients in the plasma light group, which is 21.8%, versus 530 of 2,413 patients in the saline group, which is 22%. So 21.8 versus 22%. 90-day mortality, not statistically significant. They also performed a secondary analysis of the primary outcome, which is 90-day mortality, for patients who had missing data. They used a worst best scenario, which amounted to patients who had missing data, assumed to be dead at 90 days in one group and alive at 90 days in the other. Then they reversed it to the best worst scenario, wherein the scenario was completely reversed. So even on this secondary analysis, with the worst best and the best first scenario, no significant difference existed in the 90-day mortality between the two groups. They also analyzed the primary outcome after exclusion of patients who received 500 mils or more fluid than the assigned fluid within 24 hours before enrollment, and also those who received 500 mils or more fluid other than the assigned fluid as open label treatment after randomization. So this was before enrollment, after randomization. And they also looked at the results when they combined these two, patients who received the non-assigned fluid 24 hours prior to enrollment and the non-assigned fluid 24 hours after open label treatment after enrollment. So in neither of these analyses, nor in the combined analysis, could they find any difference in the 90-day mortality. What were the secondary outcomes that they looked at? The peak serum creatinine level in the first 7 days of the study was not significantly different between the two groups. It was 155.8, standard deviation 127.4 millimoles per liter. The maximum increase in the creatinine level during the ICU stay also did not differ between the two groups. Requirement for renal replacement therapy, 12.7% in the plasmalite group versus 12.9% in the saline group, not significantly different. Duration of vasoactive drugs treatment, not different between the two groups. Also not different were the days alive and free of ventilation, alive and off ICU, alive and out of hospital, the ICU mortality, hospital mortality, and the 28-day mortality were also not significantly different between the two groups. They also performed a subgroup analysis based on age, gender, severity of illness, based on the Apache score, the presence of sepsis or no, presence of acute kidney injury or no, and whether postoperative or not. Here again, on subgroup analysis of all these different groups, they couldn't identify any difference in the primary outcome between the two groups. So in summary, the study could not find any difference between plasmalite 148 and normal saline in terms of death within 90 days of randomization, which was the primary outcome. The peak creatinine levels and the use of renal replacement therapy, also a very pertinent clinical outcome, did not differ between the two groups. The number of days alive and ventilator-free, alive and out of ICU, and alive and out of hospital were also similar between the two groups. There was no difference between groups in the ICU, hospital mortalities, and the mortality on day 28.
Thanks, Dr. Chacko. So I guess this study is quite landmark trial because it has provided us a very clear answer on this topic. Now, a lot of people criticize this trial saying that this is a negative trial and did not show the difference between two fluids. But I disagree with that conclusion because I guess this trial has definitely provided us an answer on this topic. Now, just going back and looking at the baseline characteristics. So this trial looked at fairly sick population who comes to intensive care unit with Apache of around 19, and also almost 75% of the population in each group were mechanically ventilated. So I guess that's the kind of cohort of patient that we normally see. Majority of the admissions, I must say, were actually post-op admissions. Almost around 45% admissions came from theaters, while roughly around 30 to 35% admissions came from emergency department. And that's probably the kind of typical case mix of Australian intensive care units. That might not be applicable to some of the other parts of the world where the majority admissions come through emergency department and already receive a lot of fluids. But at least in Australian intensive care, we receive majority of the admissions from the theaters, and roughly around 30% admissions come from the emergency department, which is kind of reflected in this trial. Now, in terms of looking at the patients who are admitted with the diagnosis of sepsis, roughly around 40 to 45% patients in each subgroup were admitted with diagnosis of sepsis, whether you follow definition according to SIRS criteria or whether you follow sepsis 3 definition. So I guess the both groups were fairly balanced, but also this trial included the select patients we are interested in evaluating the outcomes with regards to use of either saline or balanced salt solution. Obviously, as you mentioned in exclusion criteria, we did not have the data on patients with traumatic brain injury because plasma-lyte was deemed to be not suitable in this particular cohort of patients. So obviously, we don't know outcomes in this particular cohort. Having said that, given that the trial included large number of patients and both groups were quite equally matched at the baseline, I think that's the first and foremost strength of the trial. Now, obviously, the COVID-19 pandemic was quite challenging, and we experienced that we couldn't enroll patients in this study. And obviously, the trial investigator have to modify the sample size. And even with that, the power of this trial is quite significant, especially considering the absolute risk reduction was aimed fairly low. And then, despite of all the challenges during the COVID-19 pandemic, authors managed to recruit almost 5,500 patients, which is quite substantial outcome. First of all, congratulations to all the authors for this phenomenal effort, despite all the challenges. So coming back to the strengths of this trial, this is a multi-center, double-blind, randomized controlled trial. And I think the blinding is probably the best strength of this trial, because most of the studies which were done in the past, achieving the blinding, especially with intravenous fluid, can be quite challenging. And knowing that amount of efforts that goes behind the scene, even to procure the intravenous fluid, which has ability with the blinding, I think that's a quite challenging effort. So I guess authors managed to get the study fluids blinded from the company that produces the fluids, which was quite a phenomenal effort. And the most important aspect of this trial is the investigators studied a patient-centered primary outcome, which is the 90-day mortality. And that's, again, one of the key strengths of this trial. Now, the third strength is the trial patients received balanced multi-electrolyte solution or saline for a longer duration and in a greater volume compared to the previous trials. Because sometimes the argument can be made, if the dose of IV fluids is not adequate, we are not going to see the effect or adverse effect of that particular fluid. And in this trial, participants in both groups were exposed to significant volume of intravenous fluid. The other strength of this trial is they measured the biochemical parameters because, as I mentioned before in the intro, that the saline solution can be associated with hyperchloremia and leading to worsening AKI. And I think this trial measured all the biochemical parameters which were relevant to assess this outcome. There was a pre-specified statistical analysis plan which was published in advance, and also there was adjusted secondary analysis to examine the effects of open label trial fluids and multiple imputation to account for missing data on the primary outcome. So statistically, this trial is quite a robust randomized controlled trial, and the outcomes we have got can be trusted without any doubt. Internal and external validity of this trial is quite significantly high. And I guess this trial, even though can be considered as a negative trial, has definitely given us an answer on comparison between the saline and balanced multi-electrolyte solution, such as plasma-lyte. Now, coming back to the limitations of this trial, first and foremost is they have to change the target halfway through the trial, mainly because of the pandemic. And obviously, one may argue that obviously resulted in a slightly underpowered study. But even though looking at a 90% power with around 3.8% absolute risk reduction is quite significant. And also there was the data was missing on the primary outcome for some patients. Having said that, despite of this, I think the finding of these trials are quite reliable because the data of this primary outcome crossed a conservative futility boundary, which makes it very unlikely that the further recruitment would have had any impact on findings. The other limitation of the study is more than half of the patients in plasma-lyte group received 500 ml or more of a saline in the ICU, predominantly for the reason of a delivery of medications, because some of the medications are not compatible with plasma-lyte. For example, vancomycin, posaconazole, and that's quite a pragmatic limitation, because if you can't administer medications with certain crystalloid solutions, you can't use it. But I guess the overall volume received of saline due to this medication compatibility issue was not very high. So I guess that should not be a major problem in terms of interpreting the results of this trial. The third limitation is authors did not control or record all fluids that the patient received outside the ICU. And that can be considered as a major limitation because sometimes those 30% patients who came from emergency department might have already received a large volume of normal saline despite they were randomized into plasma-light group, or they might have received Hartmann solution when they were randomized to saline group. So we don't have that data available, and I think that might be a major limitation of this trial. Having said that, with the design of the trial where patients were randomized equally between two groups, one may assume that that effect will be nullified due to the process of randomization. Now, also the author did not examine the effects of balanced multi-electrode solution or plasma light as compared with saline in patients with traumatic brain injury. And again, that area of uncertainty still exists because nobody has actually compared plasma light in patients with traumatic brain injury. So compared to basic study and a split study, the results are pretty consistent, although these results are contradictory to SMART trial. But I guess overall, this trial has now told us that 0.9% sodium chloride or saline solutions are not harmful as we were previously thought. Or the other way to look at this is plasma light or balanced multi-electrode solutions are not much better compared to saline solutions. I guess it comes down to how much fluid we administer to our patients. If we administer less than 3 liters of fluid to our patients, I guess we are not going to see major effect on mortality with that much of dose. Obviously, if we keep administering more and more of any fluid, I guess that will cause harm. So these are my kind of initial thoughts. What's your thoughts, Dr. Chakko?
I agree with most of what you said, Swapnil. It is fairly robust evidence in a real-world study, large numbers of patients, which was of reasonably adequate sample size, even considering the fact that they had to cut down on the projected sample size midway through. In fact, one of the problems with the basic study that you discussed earlier was that the volume of fluid used was pretty restricted in that study. But in the PLUS study, the volume of fluid infused was much higher than what they used in the basic study, 3 liters plus. So that is more like a real-world scenario among particularly septic patients who need large volumes of fluid resuscitation. So this is a fairly strong evidence that in the real world, it may not really matter whether you use normal saline versus plasma light, given the volume of fluid that you use in the acute setting. Although there are some limitations, particularly in terms of patients whose data was not available, although they did perform analysis based on the worst, best, and the best worst outcomes separately. A fair number of patients received a different type of fluid compared to the assigned fluid for the reasons that you've already mentioned. Some of it, of course, cannot be avoided because you tend to use normal saline with most of the mixing solutions, although you can change it to alternate fluids in case of infusions of vasopressors and so on. There are specific drugs that wouldn't require dilution with normal saline, so that you cannot really avoid in the clinical situation. The patients who had open label normal saline was a significant number, 63% in the plasma light group, which may have led to some bias, as was the use of non-assigned fluid in situations out of the ICU, like theater, emergency department, and in the wards later on as well. So all these may have confounded the results, but I think overall, this constitutes pretty much strong evidence that it doesn't really matter one way or the other, whichever fluid that you may use during the resuscitation phase. The patients that they studied were fairly typical of a general ICU, Apache score of 21 or so, which is fairly similar to what we see among our patients. At the same time, you need to look at the SMART study and the SALT bed study, which were published a couple of years ago. They, of course, did not use a single outcome. They used composite outcomes, including the 90-day mortality. So that actually did show a difference in the composite primary outcome. But when you looked at the actual 90-day numbers, it didn't make a difference. So overall, in terms of mortality, the choice of fluid between normal saline versus plasma light doesn't seem to matter. And Against this background, we had this meta-analysis published in the NEJM Evidence, which is a new journal, in which they included 13 randomized controlled trials with 6 studies with a low risk of bias. And in fact, they performed a Bayesian meta-analysis as well using vague priors. And they found that the probability of 90-day mortality was 89.5% lower compared to saline. So that is, again, some suggestion that we perhaps cannot come to an absolute conclusion at this time. And perhaps there is room to stick to a balanced salt solution in many clinical situations, apart from, of course, patients with traumatic brain injury and patients who are at risk of cerebral edema. So the question may not be finally answered. We still need to keep an open mind on this topic, I would.
Yeah, that's very interesting for me because I guess that couple of things. I think this trial has clearly stayed away from using the terminology normal saline because there's nothing normal about saline. So I guess 0.9% sodium chloride or just a saline solution, that's kind of new terminology. And also looking at the meta-analysis, there included 13 randomized controlled trials. Out of that, only 6 trials had a low risk of bias, had a 90-day mortality as an outcome. And overall, when they compare risk ratio between two groups, it was 0.96. So it was not kind of much difference. And when they looked at the confidence interval, it kind of comes from 0.91 to 1.01. So although it's not significant, what they're saying is probably there is signal towards more benefit because confidence interval is swaying towards more benefit with balanced salt solution compared to saline solutions. So there is some signal based on the meta-analysis of all these 6 trials with low risk bias, which included roughly around 34,500 patients. So it's a quite significant patient population, and I guess that signal can be ignored. Having said that, in terms of administering the fluid, the fundamental practice should be stop using intravenous fluid once the resuscitation phase is over. What tends to happen in most of the intensive care units at the moment is even after they come to intensive care unit, after resuscitation in emergency department or in theater, all of these patients start getting maintenance fluid at 60 mil, 80 mils, or sometimes 125 mils per hour, which basically results in a lot of IV fluid volume administered to this patient. So I guess that's the bad practice, which we need to change over the period of time. Because technically patients do not need maintenance fluids, and even this amount of fluid patients receive just with medication is quite significant. And I think this is what this trial has showed, that despite patients were admitted to intensive care unit post-operatively, they ended up in getting almost 3 liters of fluid just as a part of the maintenance and as a part of the medications carrier fluid. So that's a quite significant burden in terms of the fluid administration to our patients. And I think that practice needs to be changed, because then it really doesn't probably matter in terms of which fluids to use. And there might be a subgroup of patients, like, for example, sepsis, where extra salt load or extra chloride load might be quite bad. Similarly, patients who had at the baseline higher creatinine, they might get more harm with the use of high chloride containing solutions. So there might be subgroup of patients who are not suitable for saline solution administration. And obviously doing a trial with particular subgroup in that kind of numbers can be quite challenging. So at the moment, the overall results are equivocal in terms of which fluid is better or which fluid is worse. I guess that's why it comes down to the routine practices, and anything in excess is bad. And I think that's the main takeaway from this trial. It really doesn't matter which fluid you use. It really matters how much you use and in which cohort you use these fluids. So that's the kind of main takeaway.
Swapnil, I would like to ask you, would you change your practice based on this study? What is your current practice, and would you change it based on this results of the study?
Yeah, so I really stayed away from using plasma light in every single patient. predominantly because of the cost issue as well. And nowadays, I don't administer maintenance fluid that much. And Hartmann's or Ringer lactate solutions are equally good and probably much cheaper than Plasma-Lyte solutions. And especially when the patient comes with DKA type of resuscitation scenario, then I tend to stay away from 0.9% sodium chloride solutions, predominantly because of the volume they need to receive in that kind of situation. So my practice has already kind of changed even before this trial. And I guess I don't tend to use Plasma-Lyte as a default solution in all patients now. Either I sway towards Ringer lactate or 0.9% sodium chloride for boluses in moderation.
Well, we use Ringer's lactate as our default solution for most of our patients, except those with traumatic brain injury and patients who are at risk of cerebral edema. And we hardly ever use Plasma-Lyte 148, largely because of the cost involved. And there is nothing in our book to suggest that it may be advantageous compared to Ringer's lactate. So I don't think this study will change our practice. We will stick with Ringer's lactate solution in most of our patients. And normal saline, of course, would be used in traumatic brain injury and other neurological injuries, which we have a substantial number.
Yeah, and I guess that's a fair call because I guess technically you use IV fluids only when patient actually need it. And in that case, if you have an option of Ringer lactate, which is quite reasonably, I guess, balanced solution, there is nothing wrong in using Ringer lactate because at the end of the day, if you compare the cost one-to-one basis, I guess that comes down much cheaper option than Plasma-Lyte. So yeah, I guess only thing changing for me is just to think about why these patients were needing 3 liters of volume of any fluid in post-operative phase. And I think that's something I tend to question myself before administering any fluid now. Does this patient really need maintenance fluid? And if the answer is no, then maybe the best thing is to stop using IV fluids in these patients. So that's the end of our today's podcast. Thanks, Dr. Chacko, for your time. Thanks, listeners. We'll be back in week's time with another controversy in critical care. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. Till we meet next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.